All right, let's dive into this explainer where we're going to demystify the World Health Organization's clinical protocols. We'll be looking at exactly how first responders manage to bring order to the absolute chaos of medical emergencies. This isn't just theory. This is the literal blueprint for saving human lives when every single second counts.
Just picture the unpredictable, incredibly high-pressure environment of an emergency scene. We're talking blaring sirens, sheer panic, totally unpredictable surroundings, and a patient who is rapidly declining. In these intense moments, making the right call in those crucial first few minutes is literally the difference between life and death. There is absolutely no time to hesitate. You need a rock-solid system. To see exactly how the pros handle this, we're going to break down this incredible manual step by step. We'll look at order in the chaos, the universal approach, CABCD, trauma, shock, and burns, poisons and environmental threats, protecting the vulnerable, and wrap up with a global lifeline.
Starting right off with Section 1, Order in the Chaos.
The goal here is simple but absolutely monumental. Eliminate the guesswork. What's so crucial about this idea is its core mission. It's all about giving every single provider, no matter what their training or resource level is, a totally clear, evidence-based blueprint for consistent care. It essentially ensures that whether you're dealing with a massive heart attack or a horrific car crash, the initial response is standardized, safe, and highly effective.
Moving on to Section 2, the universal approach, specifically the CABCDE method.
You see, before a paramedic even thinks about diagnosing a specific problem, they run through a universal checklist that has to be done in the first 5 minutes, no exceptions. Enter the CABCDE approach. It's a primary survey that practically forces the brain to prioritize immediately life-threatening issues in a really strict logical sequence. First up, stop catastrophic bleeding. Think tourniquets or wound packing. Then check the airway. Is it open? Next is breathing. Are they getting enough oxygen? That's followed by circulation, then disability, and finally exposure, which means fully checking the patient's body for any hidden injuries. You simply cannot move to step 3 if step 1 is killing the patient. It's that critical. Let's zoom in on step 5 for a second. Disability. Providers aren't just guessing here. They're following a highly specific scientific pathway. For instance, if a patient is acting confused or has an altered mental status, the protocol says to immediately check their blood glucose. Why? Because a severe blood sugar crash can actually mimic a massive brain injury. If they suspect a stroke, they launch straight into a fast assessment, checking facial movement, arm drift, and speech impairment. It is swift and it is incredibly targeted. Let's head into Section 3, trauma, shock, and burns, looking at specialized pathways. Okay, so once that baseline primary survey is locked in, the protocols pivot into specialized pathways. It's fascinating how they use this branching logic, based entirely on the patient's immediate physical state. Take a choking victim, for example. There's a massive divergence in what you do next. If the person is conscious and coughing, you actually step back. You encourage them to keep coughing and try to keep them calm. But the very second they go unconscious, the pathway instantly flips to chest compressions, opening up the airway, and trying to physically remove the object. The immediate physical signs completely dictate the medical path. And it gets even more precise when we're dealing with deeply complex issues like shock. First responders use these rapid-fire diagnostic checklists. Say a shocked patient has swollen ankles, a wet cough, or crackling sounds in their lungs, the protocol immediately flags cardiogenal shock, meaning the heart itself is failing. This radically changes the game plan. Instead of pumping them full of IV fluids and laying them flat, you actually have to sit them straight up and severely restrict their fluids so they don't drown in their own secretions. Now let's talk about the exact science here, because when responding to severe burns, guesswork is literally lethal. There is an exact mathematical formula used to calculate massive IV fluid requirements. 4 milliliters multiplied by the patient's weight in kilograms multiplied by the total body surface area burned. And get this, the protocol mandates delivering exactly half of those calculated fluids in just the first 8 hours from the time of the burn. We're talking about incredible, life-saving math executed under extreme pressure.
All right, Section 4, Poisons and Environmental Threats.
Imagine arriving at a chaotic scene. You've got an unconscious patient and you have absolutely no idea what they took. Well, the WHO protocol teaches responders to treat unknown poisonings exactly like a detective. They do this by mapping out things called toxidromes. Basically, a paramedic can deduce the exact category of poison a patient ingested just by looking at 3 or 4 visual clues. pinpoint pupils with dangerously low breathing, that's an opioid toxidrome. Dilated pupils, sweating, and extreme agitation, that points to a sympathomimetic toxidrome, like a stimulant overdose. The body literally tells the story if you know how to read the physical signs. And once that rapid-fire detective work is done and the toxidrome is identified, the protocol instantly unlocks the correct antidote. If the signs point to opioids, responders immediately administer naloxone. If it's a cholinergic poisoning, something like toxic pesticides, they push atropine. The protocol gives them the exact keys to reverse those deadly effects right there on the spot. Moving to Section 5, protecting the vulnerable, specifically looking at pediatrics and pregnancy. So, you obviously can't treat a 6-year-old or a pregnant woman exactly the same way you treat a 40-year-old man, right? The anatomy is fundamentally different. For pediatric care, a provider probably isn't going to have a scale handy in the heat of the moment, but they can use an incredibly simple, clever mathematical formula. Just take the child's age, add 4, and multiply by 2. This instantly estimates their weight in kilograms. It's an absolute game changer for ensuring safe medication dosing, because giving a child an adult dose, that can be catastrophic. Also, because children have larger heads, softer necks, and totally different physiological reserves, they can actually compensate for a surprisingly long time and then suddenly crash. Because of this, providers are trained to constantly, obsessively scan for specific, rapid-fire danger signs. We're talking about things like chest indrawing, nasal flaring, and cyanosis, which is a scary bluish color around the lips or fingertips. Spotting any of these triggers an immediate, massive escalation in care. Now, for pregnant women, the stakes are equally high. If a mother experiences postpartum hemorrhage, which is massive bleeding after giving birth, the protocol triggers what's called the MOT bundle. It is a strict, non-negotiable 4-step action plan. Massage the uterus, administer an oxytocin drug, push tranexamic acid to help her blood clot, and establish IV access. And the most critical part of this whole shebang, the manual explicitly states this entire bundle must be fully executed within 15 minutes to save her life. Let's hit our final section, Section 6, a global lifeline. We've spent time looking at some really granular clinical steps, but we need to zoom out and see how these scalable procedures act as a literal lifeline across the entire planet. These algorithms are completely brilliant because they represent the gold standard of international best practices, but they are deliberately designed to be adaptable. The WHO knows full well that an ambulance in rural sub-Saharan Africa might have very different equipment than a high-tech paramedic unit in downtown Tokyo. So these protocols provide the clinical standard, but leave room for local medical directors to adapt them to their specific resources, local laws, and scope of practice. But here's the beautiful part. Regardless of whether an ambulance is weaving through a major metropolis or bumping along in a remote village, universal targets remain exactly the same. Take maintaining a patient's oxygen saturation, for example. The goal is always to keep it above this golden number, 92%. It's a universal metric, ensuring that everyone, everywhere, gets the absolute best possible foundational care when they are at their most vulnerable. Which ultimately leaves us with a really vital question to consider about our own local preparedness. If an emergency happened right in front of you today, are your local responders equipped with these universal life-saving protocols? It takes an absolutely incredible global effort to make this level of care a standardized reality. So the next time you hear a siren wailing in the distance, just think about the rigorous, highly structured algorithms guiding those responders right through the chaos. Understanding this isn't just about medicine, guys. It's about understanding the very architecture of human survival.